Heart failure is one of the more common things that we see in the hospital. The thing you do have to realize is when somebody tells me they have heart failure, they really haven't told me anything. There are lots of different types of heart failure, and it's real important that we know what type of heart failure we're dealing with because they can have different treatments. So first thing I want to do, let's talk about the normal heart function. What I have done here is I have basically taken a heart and unraveled it. The heart is of course one structure, but from a functional standpoint, we can consider it like this. You have a right side to the heart. You have a left side to the heart. Each side of the heart has an atrium and a ventricle. That's where you get your four chambers of the heart. And so what sits in between the right side of the heart and the left side of the heart is the lungs. So think of the right side of the heart as being a reservoir. It's going to collect blood from your body. It's going to pump that blood through the lungs where oxygen is added to it. And then the oxygenated blood goes from your lungs to the left side of your heart, and the left side of your heart is going to pump blood out of your arteries, and you're going to oxygenate all of your organs and tissues. And then that deoxygenated blood is collected in your veins, and it returns it back to the right side of the heart, and we do it all again. In a nutshell, that's your cardiovascular system. So again, I'm going to call it the most typical or common type of heart failure is what's called systolic heart failure. And that occurs when the left ventricle is weak. It just doesn't squeeze as well as it should. We can measure this by doing an echocardiogram, and we can measure what's called your ejection fraction. In other words, every time the left ventricle squeezes, how much blood actually leaves the ventricle and is propelled forward. So normal is like 50 to 60%. So if it's less than that, you have some degree of systolic heart failure. So with systolic heart failure, if you have a weak left ventricle and you're not moving blood forward like it's supposed to go, it's building up behind. And so what's behind the left side of the heart is the lungs. And so one of the things that you see as a manifestation of systolic heart failure is fluid will build up in the lungs and you become short of breath. So there are lots of different treatments for systolic heart failure. One of the main drugs that we want you to be on is either an ACE inhibitor or an angiotensin receptor blocker. Now these are blood pressure medications. They are going to decrease your afterload. And when I talk about afterload, what I'm talking about is the right side of my drawing here. Think of it as blood pressure. That's the pressure your heart's having to work against in order to circulate your blood. But in addition to decreasing the afterload, it also decreases the preload. And think of preload as being on the left side of my drawing. Think of preload as standing behind a car and pushing it up a hill. The more people you have back there pushing, the higher the preload, and the easier it is to get blood through the right side of the heart and the lungs and over to the left side of the heart. But if the preload's too high, that can adversely affect heart function. And so again, ACE inhibitors and angiotensin receptor blockers are going to decrease both the afterload and the preload. But by doing so, they decrease the workload of the heart, and they also prevent remodeling of the heart. Remodeling of the heart is something that happens in heart failure. It causes the heart to change in size, shape, and structure, and ultimately that adversely affects the function of the heart. So now the problem we potentially have with ACE inhibitors is, as I've already mentioned, they are a blood pressure medicine. And so we count on people having an elevated blood pressure in order to be able to aggressively treat with these drugs, and not everybody necessarily has an elevated blood pressure. The other thing about ACE inhibitors and angiotensin receptor blockers is they can adversely affect kidney failure. The unfortunate reality is that most people that have significant heart failure also have some degree of kidney dysfunction. They really just go hand in hand. And so you have to kind of balance those two organ systems against each other. I'm always willing to accept some degree of kidney failure in order to keep the heart failure well compensated. Now, for patients who cannot be on an ACE inhibitor or an angiotensin receptor blocker because of kidney dysfunction, we can use a combination of hydralazine and a nitrate. The hydralazine decreases the afterload while nitrates decrease the preload. So that combination of medicines does the same thing as an ACE inhibitor or an angiotensin receptor blocker, but without the adverse kidney effect. So in addition to those medications, we need patients to be on a beta blocker. So beta blockers are going to decrease the afterload and also drop the heart rate. And so that decreases the workload of the heart. It also prevents remodeling of the heart. And both ACE inhibitors, angiotensin receptor blockers, and the beta blockers are going to prolong survival in heart failure. A third class of medications is aldosterone antagonists. They are a diuretic. They increase secretion of excess fluid and salt, and they also hang on to potassium. And these also prolong survival in heart failure. Fourth class of medications is loop and thiazide diuretics. They are a stronger diuretic than an aldosterone antagonist, and loop diuretics and thiazide diuretics work in different areas of the kidney to, again, get rid of excess fluid and salt. But again, now these medications cause wasting of potassium, so we will often combine loops and thiazides with the aldosterone antagonists in order to try to balance your potassium levels. And then finally, that leaves diet. It's very important that you limit salt and restrict your volume. That tends to be a tall order for most patients. It is really tough to stick to any kind of restrictive diet, but it really is an important part of management of heart failure. That brings us to the next type of heart failure, and it's called diastolic dysfunction. And what diastolic dysfunction is you have a stiff and non-compliant left ventricle. So just the muscle of the left ventricle, again, tends to be enlarged, and it just won't stretch. And so what that does is it makes it hard for the left ventricle to fill up with blood. Now it can be, you can see it in patients who have both diastolic and systolic dysfunction, but a lot of times we'll see patients that just have diastolic dysfunction. And so the thing to realize is if you have decreased cardiac output because of a weak left ventricle that's just not squeezing very well, or whether it's because of a left ventricle that may be squeezing fine, but it's just not filling up with enough blood to begin with, the end result is the same. You're going to have decreased cardiac output, and fluid is going to build up behind the left ventricle and can cause pulmonary congestion, fluid buildup in the lung. So again, the manifestations are going to be the same. But this is treated a little bit differently. Our mainstay of treatment for diastolic dysfunction is going to be beta blockers to decrease the afterload and decrease the heart rate. Again, we want to relax that heart muscle, and so the beta blockers do that. They also prevent remodeling and also result in prolonged survival. Some patients can have valvular dysfunction that results in heart failure, and this will often result in systolic or diastolic failure, but not necessarily. We'll see patients come in that their systolic function and diastolic function is fine, but they have bad heart valves. So when we look at my drawing back here, we have heart valves scattered throughout the heart. Between the right atrium and ventricle is a valve called the tricuspid valve. Going out of the right ventricle and into the lungs is the pulmonic valve. Going from the left atrium to the left ventricle is the mitral valve. And finally, going out of the left ventricle into your aorta and the rest of your arterial circulation is the aortic valve. So one of the problems that we can see is aortic stenosis. And what I'm greatly exaggerating here, but let's pretend that the aortic valve is supposed to be that big around. So with aortic stenosis, it's that big around. So the opening to get out of the heart is just too small. And so as the left ventricle contracts and tries to squeeze blood out and into your circulation, it's hitting that tight aortic valve and it just can't get out. And so you can see a similar thing with the mitral valve, and that's of course called mitral stenosis. And aortic stenosis in particular can have a very high mortality. Once you become symptomatic with it, you really have to do something about it. So these days we are able to handle that problem less invasive than we were in the past. It used to be you would have to go have a big open heart surgery. They would have to cut out the bad aortic valve, and then they would replace that with either a mechanical valve or a tissue valve that they got from either a pig or a cow. And but of course that's a huge surgery. So these days what we often do, particularly in somebody who's not a candidate for a big open heart surgery, is they can do what's called a valvuloplasty, where they'll take a balloon and put it in the opening and blow that balloon up, and it pops the valve open. I can't imagine who had guts enough to do that the first time, but somebody did. And that will give you some temporary relief. That is not a permanent fix, but that will buy you a little bit of time until you do something else. And so that something else in this situation is often what's called a TAVR. And with a TAVR, they can basically put an artificial valve on the end of a catheter, run it up into here, put it in place, and they deploy that valve without ever removing the old, your native aortic valve. And those things work really well. And so we have a lot of particularly elderly patients who just aren't a candidate to have anything else done, and this can really help them greatly. So now, of course, we have not only can you have a stenotic valve, but you can also have a valve that doesn't close properly, because when the left ventricle squeezes, what you are expecting to happen is for the mitral valve to close and the aortic valve to open. And so that way, when the left ventricle squeezes, all the blood goes that way. But a fairly common valve dysfunction we see is what's called mitral regurgitation. And again, that's where the mitral valve doesn't close properly. And so as the left ventricle squeezes, some of the blood goes where it's supposed to go, but some of it is quite literally going to go backwards. And once again, you're causing increased pressures in the lung, filling up with fluid, and your typical heart failure symptoms. You can have a similar process over here with the aortic valve. You can have aortic regurgitation, and with that, you pump blood out, but then as the heart is relaxing and getting ready to fill up with fluid again, it sucks some of that fluid, the blood, right back into the left ventricle. With significant heart failure, one of the complications that can occur is a condition called pulmonary hypertension. And what pulmonary hypertension is, it's high blood pressure in the lungs. Your lungs have a blood pressure just like your arm has a blood pressure. The difference is the blood pressure in the lungs is supposed to be really low. And so that makes it easy for the right side of the heart to pump blood through the lungs. So if you put the right side of the heart under increased stress, like with pulmonary hypertension, that can then lead to right-sided heart failure. So with right-sided heart failure, this is a problem. You know, we have lots of potential treatments for left-sided heart failure, but for right-sided heart failure, it's just simply more problematic. What I want to do is I want to draw a graph. This is called a Starling curve. Let me be sure this is showing up on the, yeah. If we look at a curve and we're plotting cardiac output against preload, you remember we spoke about preload a little bit earlier. As your preload goes up, you can see that your cardiac output goes up, but you reach a point where if you continue to add preload, the cardiac output will start going down. And so this can be a particular issue in pulmonary hypertension and right-sided heart failure. And what happens to you is you just have so much preload, think of that as just the blood volume, that it is just, it is stretching the right side of the heart to the point where it's just unable to contract. And so that's what we often see with right-sided heart failure, is that the right side of the heart's just not able to handle the blood volume that's being presented to it. And so whereas with left-sided heart failure, a lot of our manifestations were because of fluid buildup in the lungs. With right-sided heart failure, what we're seeing is a lot of swelling just basically everywhere else. Now, you see this with left-sided heart failure as well, but again, it's a particular problem with right-sided heart failure. In fact, you can see people coming in just grossly volume overloaded and edematous, and their lungs look fine. There's not any fluid in the lungs at all, but it's everywhere else, particularly down in the legs and the scrotum. So the interesting thing that happens with somebody who has an excess of preload is as you put them on diuretics, because understand that normally when you put somebody on diuretics, you're going to adversely affect their kidney function. Again, because you're pulling out blood volume from them, and the kidneys are very susceptible to injury from decreased blood volume. But if you're grossly volume overloaded, interesting thing will happen. As you start dropping that preload, you can see all of a sudden our cardiac output starts going up rather than down. And you will actually see people with significant right-sided heart failure, as you diurese them, instead of a kidney function getting worse, it gets better. And with those patients, I'll continue to diurese them until I see their kidney function starting to deteriorate. And that tells me I've taken off as much fluid as I can. But with right-sided heart failure, there's really not much else to do other than diurese them as their kidney function will allow you to. So as you can see, there's several different types of heart failure, and they all have different treatments. And so again, it's very important that we understand exactly what type of heart failure we're dealing with, and so that's the reason we check echocardiograms. We'll get most of the information we need from that. And but you really do have to help yourself out. You have to take your medications, and as much as I can get you to, I need you to watch that diet. Now, in regards to what can you do at home as far as your medications go, what I often ask patients to do is, once I have them as compensated as I think I can get them while they're in the hospital, what I always recommend they do is go home, pee, strip naked, weigh yourself, and write that weight down. That's going to be your target weight. That's what we want you to weigh. And then every day after that, wake up in the morning, pee, strip naked, weigh yourself. And if you're ever more than 3 to 5 pounds over your target weight, you don't gain 3 to 5 pounds of fat overnight, but you can put on 3 to 5 pounds of fluid. So we're using your body weight as a marker for how much excess fluid you're hanging on to. So again, in the event that you see you have put on excess water weight, you can increase the amount of diuretic that you're taking. Say if you were taking 40 milligrams of Lasix once a day, well, take it twice a day. If you were already on 40 milligrams twice a day, maybe take 80 in the morning and 40 in the evening. Again, just take extra diuretic until you get your body weight back within range. On the other hand, if you see that you're starting to lose weight and you get more than about 5 pounds lower than your dry weight, you may be a little bit too dry, and so it may be reasonable to hold a dose of diuretic until your weight comes back in. So again, you can really do yourself a favor by watching those body weights, and you can prevent hospitalizations by adjusting the diuretic dosing on your own. I don't think most physicians would have a problem with you doing that, as long as you understand the strategy behind it. So that's heart failure.